Good afternoon, everyone. My name is Simran Chaudhary, and I welcome you all on behalf of Voice of Healthcare to the panel discussion on sepsis, AMR, and infection control, empowering healthcare with affordable diagnostics and stewardship. Today's conversation will revolve around the unique challenges in diagnosing infections, particularly in resource-limited settings, and the role of affordable diagnostics in improving patient care. Our panelists will share insights onto how rapid diagnostic tools impact antimicrobial stewardship and infection control. And more can be done to make diagnostics accessible and cost effective for all. I'm thrilled to introduce our esteemed panelists, who all of whom bring a wealth of experience and expertise in the field of infectious disease, and is going to break us spread awareness on this sepsis panel discussion. I would like to introduce Dr. Vidya Krishna, infectious disease specialist, Apollo Children Hospital, Chennai. Welcome to our show, Dr. Vidya.
Hello, Simran.
Dr. Vasant C. Nagvekar, Director, Department of Infectious Disease, Sir H.N. Reliance Foundation Hospital.
Hi, good afternoon to everybody. Hi, sir. Hi,
Hi,
Vidya.
Vasant.
Good afternoon, Dr. Vasant. Dr. Madhuri Somani, Consultant Microbiologist and ICO, PSRI Hospital, New Delhi. So she'll be joining us shortly for this program. Okay, she's here. Dr. Abdul Ghafur, Infectious Disease Specialist, Apollo Hospital, Greams Road, Chennai. Welcome to our show, Dr. Abdul.
Hi, Simran.
So, Dr. Abdul Ghafur will be moderating this session and will be taking forward from here. So, without any further delay, I hand over the stage to Dr. Ghafur to dive right into the discussion and begin with this panel discussion.
Thank you, Simran. Good afternoon, everybody. Welcome to today's webinar, and that's on empowering healthcare with affordable diagnostics and stewardship. And it's a privilege to moderate this important discussion. And we will focus on the pressing need for affordable and accessible diagnostics across all infectious disease syndromes. However, given that respiratory infections are the most common and widespread, we will concentrate on these infections today. And respiratory infections like flu, respiratory syncytial virus, and COVID-19 contribute significantly to global morbidity and mortality, particularly in vulnerable population like children, elderly, and immunocompromised patients. And affordable diagnostics are essential in addressing not only respiratory infections, but also other range of infectious disease syndromes, ensuring timely and accurate diagnosis, improving patient outcome, and supporting antimicrobial stewardship. And we have with us Vidya Krishna, who is a pediatrician, Vasant Nagvekar is an adult infectious disease specialist, and Madhuri Somani is a microbiologist. And together, we will explore these challenges. And the first question, Dr. Vidya, you are a pediatric infectious disease specialist. What are the unique challenges in diagnosing respiratory infections in children, especially in a low middle income country like India? And how can affordable diagnostics address these challenges to improve pediatric healthcare? Dr. Vidya.
Good afternoon, everyone, and thank you, sir, for that first question. So, India definitely has a very high burden of respiratory infections, and we have a huge vulnerable population, be it your infants, preterms, congenital anomalies, whatever. So, we have a significant problem. The first challenge which I obviously see is access to healthcare. But if I'm not going to talk about access to healthcare, then I will actually come to what happens once you reach healthcare. Are you guaranteed that you're going to be getting the best diagnosis and the best treatment? Unfortunately, I don't see that there is a standardized care across all sectors in India. Like if you have worked abroad anywhere, then you would know. Relatively, if you compare, there is no standard care. So we have a lot of standard treatment guidelines. There is a lot of educational resources, online teaching, which happens every now and then, continual medical education. There is enthusiasm among healthcare workers to upgrade themselves and keep updating their knowledge. But whether knowledge gets translated into practice is one problem that I see. Why this problem is there is because I think most of our treatment guidelines are based on history, clinical assessment, and then you go ahead with the treatment. But it's not so straightforward. I'm just going to take one example. For example, pharyngitis is a very common syndrome that all pediatricians see in practice. We all have been using the scoring system, the Centaur scoring system. If it is 0, you don't give antibiotics. I understand that. If it is 4, you give antibiotics. I understand that also. But if it is somewhere in between, do I wait and watch or should I not? Should I give the antibiotic today or wait and watch? That's the problem. If you have a simple test, a point of care test like a rapid streptococcal antigen, it just changes the entire scenario. So, in those clinics or those hospitals where they use this point of care antigen test, then the antibiotic prescription is more likely to be it's more standardized, and then it's more likely that you will not be abusing antibiotics. Say other syndromes like otitis media, pneumonia, we don't have good point of care testing or good diagnostic tools which are easy and readily available for a clinician to rely on when he has a doubt. So I think the biggest challenge is having good diagnostics, rapid or point of care diagnostics for us to rely on and proceed with our management.
Thank you, Vidya. Well said. We need rapid point of care diagnostic, and we need affordable, accurate, and accessible rapid point of care diagnostics. Vasant, you are an adult infectious disease physician. In your experience, how rapid point of care diagnostic will help us in proper patient management and in our antibiotic stewardship?
Thanks, sir. Thanks, and good afternoon, everybody. I think in adult population or wherever I'm practicing, whether in my private clinic or whether I'm practicing in HN Reliance or Leelavati, the major, I think, having a rapid diagnostics at an affordable rate will be a good antimicrobial stewardship. Otherwise, what's happening is the present costing is 3,500 to 6,000 anywhere, and with every uh, if the patients, I think even if somebody is affording, if you tell him to do a 5,000 test, he may not be willing to do that. And then what happens is somebody has come with to you with URTI, and more than 90 to 95% of the URTIs are viral infections. So what happens is when you're not able to diagnose that fever with URTI, you tend to give them oseltamivir because that is the only weapon we have as of now to be given. So I think by having a rapid diagnostics at a very affordable rate, it will not only it will be having a very good antimicrobial stewardship, and also you'll be correct in your diagnosis. So I would see three advantages. One is good antimicrobial stewardship. Second is good diagnosis, restricting usage of oseltamivir unnecessarily, which is over abused where it is not required. And third thing is I would say is to know, it will also help to know the epidemiology of what is happening in your city or your state. I think these three. So I think a rapid because at my level, ID level, no, I can afford to convince the patient to do the test and get it done. And so I also do many time tests to know what's happening in my city. So that helps indirectly the other patients. So I think, but if your tests are affordable, we can have large number of patients doing this test, and so it will help not only clinicians, also the patients as well, for not using the medications unnecessarily. So I see three points: antimicrobial stewardship, misuse of drugs will be reduced, and third is I think to know the epidemiology, what's happening in your city and the state.
Thank you, Vasant. As you very well pointed out, we are over prescribing oseltamivir because we don't routinely test for these viruses in all our patients. And for high risk patients, we just prescribe oseltamivir. And that is over prescribing, and over the long term, it will lead to oseltamivir resistance. And also, if you know it's a virus infection, we don't have to prescribe antibiotics. So if you don't know it's a virus, we are prescribing an oseltamivir, and also we are prescribing an azithromycin or comoxiclav. That is antibiotic overusage. And if you don't test, how do we know what is the epidemiology?
I think we lost right, Vidya.
Yeah, yeah. Madhuri has not joined as well. So
Yes, we
yeah.
are back. For a moment, we were out. So, uh, so Vasant, what are the currently available rapid point of care diagnostic available? It's virus test, not the biomarkers in your
So
practice.
yeah, so the presently while tests which are affordable is one is RT-PCR for COVID, which is available. Then RT-PCR for H1N1, which is available. Then we have the RSV flu panel gene expert, which is available, which only tells you about influenza A or RSV or B. Then we have a combination of RSV flu panel, which talks about RSV, influenza A, B, or COVID. So I think these are the rapid tests which we get. Then we have the respiratory biofire, which is very expensive, which is tells you about a lot of other viruses, which cost you around anywhere from 12,000 to 20,000, depending on the city and the hospital which you're dealing with. So these are the few rapid viral diagnostics tests which are available, and plus some antigen tests which are available, like influenza A, B antigen tests, but they are not very reliable. And then we have point of care COVID antigen tests. Again, those are also if they're positive, it helps you, but negative does not rule out. So these are few tests which are available in present.
Right, she said we have Biofare, which is a wonderful test. The only problem is Biofare is too expensive for most of the patients. And I work in a very five-star, me and Vidya and you, and we all work in big private corporate hospitals. And even for many of our patients, such expensive tests are not affordable. But it's a very good test. We need to say that. And we have got the other test, triple panel test, expert test, which is definitely more affordable than the Biofire, but still is expensive for many of our patients. And we are not able to do this test for all the patients that we need to test. And many of our general ward patients or semi-private route or even private ward patients can't afford expensive tests. So what will be the scenario in majority of the ordinary private hospital? And what will be the scenario in government hospitals? And that's the challenge that we face today. We need affordable, accessible, at the same time should be accurate rapid diagnostic tests, accurate as the gold standard test available. And Vidya, you're a pediatrician.
Yes.
How common is the RSV in your practice?
RSV is become a very common problem, especially post-COVID. I think a couple of years that we were under lockdown and maybe the non-pharmacological interventions, as they say, or masking and other things really helped to keep RSV down. But it has just come back after that. After COVID, every year we have had a problem with RSV. This year also. And every year the season seems to be shifting a little early. Like we have started seeing it from August onwards. Earlier it used to be sometime in October and November and all those. So it is a big problem, and it is a problem, especially as I already said. We have a large vulnerable population: children, infants, children under 5 years, preterms, ex-preterms. India has a large population of ex-preterm population, and then a lot of congenital anomalies, cardiac problems. So it is a big problem, big healthcare burden. RSV is a big healthcare burden in India.
How bad is RSV? For example, me and Vasant, we are adult infectious disease patients. Of course, in our oncology practice, it's important. RSV is a bad virus. In our BMT patients, it's a bad virus. But most of the adults, RSV doesn't create much trouble except elderly above 65. But pediatrics, the situation is very different, isn't it? I remember talking to you about RSV, and you are always concerned about RSV.
Yes.
Why is that?
Yes. See, because generally all children under 5 years will definitely get at least one infection with RSV, if not 2 or 3. Okay. And the first infection is always very severe. The earlier you get it, if you get it less than 6 months or if you get it less than 1 year, it's definitely a serious infection. It can increase your hospitalization risk because it mostly causes just a bronchiolitis or a croup-like syndrome. And most of these infants would just come in and require some oxygen. But some of them do go on to develop, require mechanical ventilation. They can develop ARDS and serious complications. Having said that, secondary infections or mortality is not so high, at least where we practice. I'm not really sure what happens in the public sector and otherwise, but usually the mortality is, as mentioned in literature, is not very high. It's supposed to be less than 2 or 3%. But it can be a problem in these children as well as the other areas where we really have problem is cardiac patients with congenital cardiac anomalies. Now we have a routine in our hospital, at least we have a routine pre-op screening policy. We screen them using the triple viral test that we say, the flu, RSV, COVID, so that because post-operatively these children invariably have a prolonged hospitalization course, and there is a risk of nosocomial transmission with RSV. That's a big problem. There are units which routinely, like nurseries and cardiac units, which routinely say that there are RSV outbreaks going on. It's very difficult to control. So it can be a big healthcare problem.
Right. So it's a condition with not very high mortality, but RSV kills children, but very high morbidity. That's what you stress.
Yes.
And also a serious infection control problem. You rightly said that. A serious infection control problem in pediatric ward. So do you believe all pediatric hospitals should have RSV testing?
Yes. If you want to do good infection control, definitely. I mean, it doesn't matter, like the clinical management is not, I mean, I have always, from the time I have been studying, it is not, I have not seen any change. Like a child with bronchiolitis is going to be treated like a bronchiolitis. You're not going to be prescribing antibiotics. You're just going to give some nebulizers and oxygen. Knowing whether it is RSV or not is not going to make a big difference. But if you want to practice good infection control, and maybe in some situations where like RSV can cause atelectasis, and generally sometimes there is a tendency to overprescribe. If you're not very sure that it is RSV, then you might give an antibiotic for a child who doesn't need it. Knowing that it is RSV probably helps you step back a little and not give antibiotics. Definitely for infection control and stewardship, it's very useful to have RSV testing.
Yeah, yes, you're rightly said. That's a very valid point. So it helps in infection control. So if you don't test for RSV, the virus spreads in pediatric units, in neonatal units. Yes. And if you don't test, we give unnecessarily azithromycin or comoxiclav or amoxicillin in the pediatric population. And also how bad it is in oncology setup or a transplant setup.
Yes. So in oncology and transplant, RSV can cause severe problems. It can lead to severe LRTIs, and especially the lymphopenics are supposed to be very vulnerable. So that is only one indication where we use ribavirin for treatment in pediatrics, or I think even in adults with RSV. Yes. No other condition where ribavirin is advised. So in children with hemato-oncology problems or HSCT, early testing really helps, because then you have some drug which you can give them so that they don't develop complications.
Yes. So, Vasant, Vidya is really worried about RSV in pediatric oncology population, pediatric transplant population, and she stressed the importance of infection control in general pediatrics, general neonatology, and also the role of antibiotic stewardship. Vasant, in adult practice, what's the importance of testing for RSV?
No, I think the importance of RSV in adult population would be concerned if the patient is, I think what we discussed about, if the patient is immunocompromised by whatever means, by chemotherapy drugs, by malignancy, or patient is elderly or having a structural lung disease, then all these patients would behave more badly. Their clinical outcome may not be the same as immunocompetent people or who do not have any comorbidities. So I think definitely it may or may not, but there will be a caution in when you have such a population, and if your RSV comes positive, because you don't have much to offer except for ribavirin to be given. So I think then it's a concern, but we'll be more watchful in this population, and it will also require the same isolation precautions, but not so much as what is required in children, because it is in adults we don't bother so much.
Right. Adults, except in oncology setting or bone marrow transplant or transplant setting, we don't really, worry much about RSV. But of course, in oncology population, especially, severely immunocompromised and post-transplant population, of course,